think we are, and we're not as good probably as we say we are, and there is a big problem in applying statistics that apply to the whole group to individual patients, and that's part of the problem. Of course, we can make this as complicated as we want to make it, and fundamentally the urinary tract and the kidneys with anorectal problems is just a big long list of what I do in my paediatric urology job. And what I'd really like to do is make it as simple as I can. One useful way, I think, of thinking about some of the urological problems that we see with anorectal malformations is to think about the associations. If there are any budding or any real graphic artists amongst the audience, please feel free to come up with a really good graphic, because this is the best graphic freely available on the internet to demonstrate the Vactorel association. It's pretty good, you can see what we're talking about, and specifically what I want to talk about today are the associations related to the kidney, related to the spine, and we'll talk about some specifics in boys and girls as well, and perhaps picking up particularly in the girls because Silke can't be with us today. It's really important to remember that above the bladder is at least one kidney, sometimes two kidneys, and sometimes in my other practice a transplanted kidney. And it's also true to say that in the more complex malformations, or the higher, as we talked about earlier on with the level of the fistula from the intestinal tract, the more likely it is to have problems specifically related to the development of the kidney and the function of the kidney. Some of the investigations that we do related to that, specifically looking at the anatomy of the kidney and the plumbing of the kidney, we'll come on to in a bit. The spine is a really, really important thing, and there was a question a bit earlier on about tethering of the spinal cord. It's not just spinal cord tethering, of course. There can be frank variations of spina bifida. There can be absence or maldevelopment of the sacrum, all of which has a bearing on the way that the lower nerves from the spinal cord emerge. They can be very subtle in the way they present, and it's really important, I think, to investigate looking specifically for spinal problems, because you may see nothing at all. You may see something as obvious as an open spina bifida. There may only be fat at the bottom of a low spinal cord, which you can't necessarily see on the outside. Now, this child has got a bit of a fatty bulge there as well, but it can be really very subtle. Or even more subtle, just a little red patch or a mark at the bottom end of the back. One of the things that I'm really, really keen on in the urology clinic in general is making sure that whoever examines babies examines them from the back as well as from the front. There can be problems specifically with the plumbing. Now, I already mentioned that you can get interesting variations in the way kidneys look, and one of the important and common things that you can get is duplications of the kidney. This is a kidney that's developed in two parts, and the top part of it has the ureter that ends up going beyond the bladder, an ectopic ureter. It happens in boys and girls, but in girls has a special significance because the ectopic ureter very often opens beyond the bladder and is a specific cause of being wet. You get conditions where when the bladder empties, as well as emptying to the outside world, can reflux urine up into the kidneys as well. An important thing to know about, because it's a risk factor for urinary infection, I think it's worthwhile just stopping for 10 seconds thinking about reflux, because reflux is one of those things that urologists have changed their minds about over the last 20 years. Now, we've changed our minds about lots of things in reality, but reflux especially, and especially in the UK and Europe. We used to think about reflux as a disease that you needed to treat to get rid of the disease. And the reason we used to justify treating it as a disease is because we thought it protected kidneys. It turns out it probably doesn't protect kidneys. If your kidney has a problem that means it's going to deteriorate in function, it's going to do that no matter what the likes of me does to the reflux into the kidney. But it's very clear it's a risk factor for infection though, and that's why I think it's important to know about, because one of the things, that, as we'll talk about in a second or two, is to try and prevent infection in these children. So some of the tests, and all of you in the room probably will have come across at least some of these tests. I'd be surprised if this is a new list for people here. The commonest way of looking at the kidneys and the bladder, and in the newborn baby, the spinal cord, as well as to do an ultrasound. An ultrasound is easy to do for an ultrasound person. It's pretty cheap to do, and it's non-invasive, doesn't hurt people. We've already seen X-ray contrast tests that get done, and it's important to know the anatomy, as we saw from Simon's talk. It's important to have a roadmap for the surgeon who's going to repair the problem, to know where they're going. And it's important to know what's happening at the level of the bladder as well, and to look for reflux with a cystogram. The spine's really important to think about, because that in itself can have an influence on bladder function. In the early infant period, probably up to about 6 or 8 weeks of age, an ultrasound's really good at looking at the level of a cord, and that can predict tethered cord. But later on, when the bones of the vertebral column start to get denser on X-ray, you need to do an MRI to look at the cord, and to get more detail, you need an MRI. But we can also get a lot of information about the kidneys and the plumbing of the kidneys from MRI as well, and get information about the structures in the pelvis from MRI. And that's quite important for girls later on, when we're worried about whether or not they've got problems with duplications of the uterus, or duplications of the vagina, or ovarian problems. The trouble with MRI in little children, though, is that they need a general anaesthetic to have it done. And that's another trip to the hospital for a cannula and a GA, and then a recovery and so on. We need to think about kidney function, and the standard way of looking at kidney function, fairly crudely, but fairly usefully, is to do some blood tests. Obviously, it's much easier to say blood tests than it is to do blood tests on a 2.5-year-old who doesn't want blood tests. We need to look at sometimes at the way the kidneys have their function split between each other. Now, 2 normal kidneys, you'd have 50% in one and 50% in the other. But I said right at the very start, it's really common to have kidneys that develop as a duplication, or only one kidney develops, or they develop in a fused way. And just having that can cause trouble with the drainage of kidneys. So we end up doing tests like MAG3 to look at drainage of kidneys and the way functions split between them. Then it comes to surgery. Now, problems with the urinary tract can happen just as a consequence of the way things have developed, but of course can happen because of the surgery. We talk about trying to localise the rectum in the right place, doing the dissection to try and preserve all of the nerve supply, particularly to the bladder. The trouble is you can't see any of these nerves. And the way that the popular operation goes is to go exactly in the midline, where theoretically you're not going to damage any of the nerves. The problem is that it's quite hard to stick exactly to the midline. Sometimes nerves do come into the midline, and sometimes, particularly for problems like cloaca, when you need to move things and get them down into the perineum, you're going to be going around a structure, and that is going to denervate the structure. So just thinking specifically about some of the issues now between boys and girls. This is a urethrogram, it's a cystourethrogram. Just thinking about some of the structures that we need to be careful about when we're doing surgery. Obviously, the rectum will be attached to the urethra if there's a fistula at various levels, and it's possible to cause damage to the urethra. Every urethra that has a fistula detached from will get some scarring as a consequence, or some remnant of the fistula that's left behind, and that's something just to bear in mind for later on. And part of the problem with long-term follow-up, as we saw from Christina Kirkler's paper, the range of follow-up was from 4 to 29 years old, but the average follow-up was only 12 years old. What we haven't got is a cohort of 1,000 patients who have got 35 years or 40 years follow-up yet. And that's where problems, say for example, with a little bit of rectal lining that's left behind in the urethra might start to turn up. These are just simply, as Donald Rumsfeld would have put it, unknown unknowns. If the fistula is higher up, going through where the muscle control of the outlet is, or into the prostate, or into the mechanisms that control and allow the passage of sperms, you can cause damage there, which might have an influence on fertility in later life, or have an influence on erectile function. Again, something that I've learned from the adult clinic, we really don't talk about sexual function, and we really don't talk about erections and so on in the paediatric clinic. Nobody wants to think about their 18-month boy and what they're going to be doing in 18 years. I've got an 18-year-old, and I don't want to think about that. If we think about the girls, specific issues with the girls, I include the genital tract when I'm talking about urology, and trouble with your Auntie Margaret is quite common in the girls. That's what we call it in our house. It's common, particularly in the more complex types of female anorectal malformation, to have duplication of the vagina and uterus. Sometimes only one of them is patent, and you get collections of blood or fluid in the other one. That's not always immediately obvious, because when you're doing an operation, a uterus in a newborn baby, or a vagina in a newborn baby, is really tiny. And if you've got a duplication, it really isn't obvious. I think one of the things that our generation of surgeons has learned is that when we're handling the urinary tract of little children, to be very delicate, to be very careful, and not to remove anything that we don't know what it is. It's much more important and safer, I think, to leave alone what you don't know what it is, because it could easily be a vagina or a uterus. That brings me on to cloaca, which I think always has traditionally been in a slightly different group. It's not as easy to classify. You know, there's that scene from that Monty Python film, isn't there, where Brian is saying, "You were all individuals," and the little fella at the side says, "I'm not." And these really are all individuals, because in a cloaca, as well as the muscles and where the rectal element of it comes in, you've got the issue potentially of duplicated vaginas and uteruses, but you've also got the issue about the outlet of the bladder and the length of the urethra, and that's got a really important bearing on the longer term outcome. This is a bladder. Well, it might as well be a bladder, because the point of a bladder is that it fills and it stores and it allows you to empty at will. And that's a little saying that most of us in urology have nicked from Tony Rickwood, who was a paediatric urologist in Liverpool. Fill, store, void at will. That's all your bladder needs to do, really. When we think about the way we look at bladder function, again, there are non-invasive, simple things that we can do to look at it. We can look at how the flow rate is, whether or not it comes out in a single stream. Does it come out in fits and starts? Does it just leak out? Is it a quick flow? Is it a slow flow? We can look at how well the bladder empties. We can do a scan of the bladder after the child or young person or adult or old person or whatever has done a wee to see whether or not they're emptying to completion. We can look at the volume in the bladder, because if you can't store an adequate amount, you're either going to be peeing very frequently or you're going to be wet. Sometimes we need to take a more aggressive approach to looking at bladder function, because bladders that don't stretch very well, bladders that empty in an irregular way or generate very high pressures can be dangerous to the kidneys. And sometimes we need to do urodynamics, which involves putting a catheter into the bladder and a catheter either into the rectum or through the stoma to measure the pressure. And that's not the best day out in the world when you're about 30 odd. It's a terrible day out when you're only 6. We talked about small capacities, we talked about overactivity. There are simple things that we can do to try and address those. We can give drugs like oxybutynin or tolterodine, and I'm sure some of you will be aware of those sorts of medicines. We can use Botox to try and do that. If you can't empty your bladder effectively, then sometimes it's okay just to send your child back for a double wee or to go and do a double wee. But try and get a 5-year-old to do that when it's much more important to be out playing. We can sometimes teach people to catheterize if that's what they need. Again, that's not the best day out in the world, having to come and learn that. And then there's the real problem, something that's common, I think, amongst the higher levels of anorectal malformation, is having a poor outlet of the bladder or a poor sphincter, causing leakage. Can be really, really difficult and can be an ongoing problem well into adulthood. And then we need to keep an eye on the urinary tract, because the problem from the point of view of the kidneys is that a lot of this can be silent. You can get deterioration of kidney function without really getting any symptoms at all. Now, the likelihood of having a problem with the kidneys with a low malformation, like a rectoperineal fistula, is very low. You do need to look for it, though, so at the very least you need an ultrasound scan. The other thing we need to think about in protecting the kidneys is actually to avoid infection. And remember I said about reflux being a risk factor for infection. Well, having a bladder that doesn't empty very well is a risk factor for infection. Being a girl is a risk factor for infection. Later on in life, being a sexually active woman is a risk factor for infection, and even later on in life, the time of the menopause is a risk factor for infection. And then promoting continence. That's a really difficult thing to do if you've got the whole gamut of associations through the Vactrel association, particularly if you've got a spinal problem. Quite a lot of the adults who have intractable incontinence, even though in childhood they'll have been subject to quite a lot of aggressive surgery like bladder reconstruction, bladder augmentation, quite a lot of the adults end up either with long-term indwelling catheters or with urinary diversions into a bag. And I just want to end on, again, we've seen this theme over the course of the morning. The higher the level of the malformation, the more complexity, the more like the Star Wars infographic right at the start of the slide set, the more complicated it is. And probably the more important it is to do surveillance over the length of time that we see people. So I think we've got a little bit of time left. Maybe we haven't got a little bit of time left actually, but if there is time for a question, I'm happy to take one. So 10 years ago, we'd have said, yeah, prophylactic antibiotics, that's the way to go. But we've all now got our antibiotic stewardship heads on. And I think there's very good evidence to show that being vigilant for urinary infection is as good a measure as prophylactic antibiotics, because the problem with prophylactic antibiotics is that you've got to get an antibiotic that covers the spectrum of germs that you're getting, and germs are getting increasingly resistant. For example, trimethoprim used to be the first-line prophylactic antibiotic that we'd give. 1 out of every 3 urinary bacteria that causes infection where I live is now resistant to trimethoprim, so we can't use it. It'll probably be the same where you are, but that's the other thing, it's highly geographic. I think in motivated families who understand the symptoms and signs of infection and understand that they need to treat symptomatic cultures, because pretty much everybody who does something to the bladder, who has dilatation, will have some, particularly the girls, will have some germs in the bladder. I think if you can be sure when it's an infection and when it's not, the right thing to do is vigilance.
Okay, Alan will be back later on with another talk.
I'll be back.
Okay.